obrigado. Despite I did not understand anything in Portuguese, I think you able to say some kind words. I mean, so thank you very much. Thank you for inviting me to this meeting. I think I was here 3 years ago, and in this hotel, but maybe not in this room.
Yes, that's right.
So it's a real pleasure to be here again. And this is Institut Gustav Roussy in Budrief, Comprehensive Cancer Center of Paris. And it's probably the largest cancer center in Europe. And we have a large series of patients with thyroid cancer. This series was initiated by Professor Tugana in the 1950s, and then he gave me his position at the beginning of the 80s, and since almost 30 years, I am the head of the nuclear medicine and the Endocrinologia Oncology department in this institution. So we have a series of more than 5,000 patients with thyroid cancer. So I have heard that you're interested in the use of radioiodine in these patients, and the topic of my talk tonight will be the therapeutic use of radioiodine. We do not use radioiodine for diagnosis. We do not use radioiodine for diagnosis. So the only use of radioiodine is for therapy. So the learning objective will be the use of radioiodine in 3 circumstances: for initial treatment, for follow-up in specific cases, and for treatment of recurrent or metastatic disease. The role of diagnostic radioiodine is really minimal. And my conflict of interest tonight are with Genzyme, who sponsored my travel to Brazil. I am a member of the Speaker Bureau and a consultant for this company. So radioiodine, as you know, is a beta and gamma emitter with a half-life of 8 days. So now, patients with thyroid carcinoma are first treated with total thyroidectomy. This is recommended for all patients with a clinical thyroid cancer, except for those with a very small tumor. And lymph node dissection is associated to total thyroidectomy in patients with evidence of lymph node involvement and in patients with PTC and large tumors, so T3 and T4 PTCs. Now, the decision to treat after a total thyroidectomy with radioiodine should be taken in a multidisciplinary team by a discussion between the endocrinologist, the nuclear medicine physician, and the surgeon. It is not possible to treat these patients with thyroid carcinoma as a single physician. We should work all together in a multidisciplinary team. Why is radioiodine given after total thyroidectomy? For 3 aims. One is to eradicate normal thyroid remnants, and this is called ablation, to obtain an undetectable serum thyroglobulin in the blood. The second one is to irradiate neoplastic foci, microscopic or macroscopic, and this is called treatment, and this may decrease the recurrence rate. And third, to perform a whole body scan, a sensitive tool to detect persistent carcinoma. So this is a normal whole body scan with a small thyroid remnant in the neck with an uptake of less than 2%. Now, why is it important to eradicate normal thyroid remnants? Because cure is assessed 9 months after treatment, after initial treatment, using 2 criteria. One is normal neck ultrasonography, and the second one is an undetectable serum TG with a sensitive assay of following recombinant human TSH. The problem is that TG may be produced in the serum by normal or neoplastic cells, and the eradication of normal thyroid remnants will improve both the sensitivity and specificity of serum TG for the detection of recurrent disease. So you see here that there is no need for diagnostic total body scan during follow-up. Now, when serum TG is undetectable before thyroid ablation, this is observed in at least 1/4 of low-risk patients. Ablation may be avoided. And this was clearly shown by a study from a fellow from Brazil, Camila Nascimento, who published this study in the Endocrinologia Cancer this year. Now, the second aim is to obtain a sensitive work-body scan 3 to 5 days after radioiodine administration. And this is informative when the uptake is small, is low, below 2%. And this emphasizes the need for a total thyroidectomy in all these patients. Now, in most low-risk patients, the total body scan is normal, with only a small foci of uptake in the thyroid bed. The SPECT-CT improves the quality of images over the SPECT alone. So I think that this SPECT-CT should be used on a routine basis for performing this highly sensitive total body scan. And I've seen some SPECT-CT in the Cancer Institute this morning. In some patients, there are uptake outside the thyroid bed. Here on this lymph node in the supraclavicular here, and diffuse lung uptake, and here in lymph nodes. Now, when this total body scan is informative, when the uptake in the thyroid bed is low, below 2%, it is more sensitive that a diagnostic total body scan performed with a lower activity. So when this highly sensitive post-therapy total body scan is negative, there is no need for a subsequent diagnostic total body scan, which becomes totally useless. And the American Thyroid Association guidelines recommend to perform a post-therapy scan in all patients after radioiodine ablation. When this should be done, post-surgical administration of radioiodine. In very low-risk patients with very small thyroid tumors, less than 1 centimeter, there is no benefits and no indication when there is no lymph node metastasis. In high-risk patients with large thyroid tumors with extensive lymph node metastasis, with distal metastasis, or with persistent disease, these patients should be treated with a high activity of radioiodine, 100 millicuries, following withdrawal. These patients represent about 10% of all thyroid cancer patients, so it's a small minority of patients. We do not give, never, activities higher than 100 millicuries, because there is no data demonstrating that treatment with 150, 200, 300, 500, etc., 700 provide better results than 100 millicuries. So the standard activity in midriff is 100 millicuries. Now, there is a third category of patients who are low-risk patients. By definition, these low-risk patients have a low risk of persistent or recurrent disease. And administration of radioiodine is aimed at the eradication of normal thyroid remnants for improving the results of serum TG determination and for performing a total body scan to assess completeness of surgery. But in these low-risk patients, because the risk of persistent disease is extremely low, there is no need to administer a therapeutic activity. So we, in recent years, try to improve the quality of treatment in this low-risk patient by improving the quality of life and by decreasing the body radiation exposure. And this can be achieved by using recombinant human TSH instead of withdrawal and by administering the lowest effective activity, 30 millicuries, and not high activities of 100 millicuries or even more. Recombinant human TSH is administered by intramuscular injection on 2 consecutive days, and radioiodine is given on the day after the second injection. It is well tolerated and has no toxicity. The advantages. One is that, so this is a room in my department, and we have a Geiger counter on the roof of each bed. So every 6 hours, this gamma counter counts the counts, and the patient is in his bed. So we have curves like this, and this is a very easy to calculate the effective half-life of radioiodine in the body. So we did this in 200 patients treated either after withdrawal, and the half-life of radioiodine in the body was 16 hours, and only 10 hours in patients treated after recombinant human TSH. So the use of recombinant human TSH will decrease the radiation dose to the body by more than 60%. Lower body radiation dose. And because the half-life is shorter, there will be also a lower exposure of relatives when the patient will leave the hospital. A second interest is that you can predict when the patient can leave the hospital. In France, the threshold for discharge from the hospital is 20 millicuries. So we have to keep in the hospital all patients who have more than 20 millicuries. See here, these are patients in black, patients treated after recombinant human TSH, and with 100 millicuries. They could all be discharged after 36 hours, 2 days. But patients treated after withdrawal may remain in the hospital for 5 days or even more. So for the organization of the department, it's much easier to treat with recombinant human TSH than with withdrawal. The duration of hospitalization is much shorter and it can be predicted with much more accuracy. Third advantage in terms of dosimetry is that the radiation dose to relatives when the patient leaves the hospital was less than 50 microsievert as a cumulative dose in 3/4 of relatives. So very low radiation dose to relatives. And this will be published very soon in Tireoide. Furthermore, there is no hypothyroidism and a better quality of life, there is no toxicity and no complication. So all these advantages of recombinant human TSH. Now, the use of recombinant human TSH has been validated for the administration of 100 millicuries. And this is a prospective randomized trial published by Pacini as first author 5 years ago. And ablation was obtained in all patients treated with 100 millicuries, either after withdrawal or after recombinant human TSH. So when using 100 millicuries, the efficacy of recombinant human TSH is similar to that of withdrawal. And this led to the EMEA approval and to the FDA approval.